Hello, hi. We are going to start with infectious disease, and today we are going to study about meningitis. So, this is the British Infection Association pamphlet for early management of suspected meningitis and meningococcal sepsis in immunocompetent adults. So, this is a fairly old edition, but it stands true now as well for the management of meningitis. What are the early recognition? Consider meningitis if any of the following are present, especially headache, fever, altered consciousness, neck stiffness, rash, fever with rash, seizures, and shock. So, most of the patient will come with headache, and you need to ask them if they have any upper respiratory tract infection or any ear infection in the recent past. They might not come with fever, but they might come with photophobia and phonophobia. So, any headache with phonophobia might be migraine, but it can be meningitis as well. So, you need to have a detailed history regarding this case. Anyways, if the patient is severely ill, you need to go for the immediate action. So, you will do the ABCD. You will ask for senior review and critical care review if any of the warning signs are present. So, what are the warning signs in this? The following signs will be if there is a rash which is rapidly progressive. And in which case do we get a rash in meningitis? So, we get it in streptococcal. So, rapidly progressive rash, poor peripheral perfusion, the capillary refill time is more than 4 seconds. The patient is oligouric or the systolic blood pressure is less than 90. If the respiratory rate is less than 8 or more than 30. Pulse rate less than 40 or more than 140. Acidosis pH is less than 7.3 or the base excess is worse than -5. White blood cells less than 4, lactates more than 4, Glasgow Coma Scale less than 12, or drop of 2 points than what it was initial. And if there is a poor response to initial fluid resuscitation. So these are the warning signs. Any of these are present, you will be allotted in any of these. So if the patient has got suspected meningitis, that is just meningitis without any signs of shock or severe sepsis or any shift of brain. So in that case, you will draw blood cultures, you will perform lumbar puncture, then you will start with DEXA 10 mg IV. You will either give ceftriaxone or cefotaxime IV immediately following the LP. CT scan normally not indicated. You need to do careful fluid resuscitation and avoid fluid overload. If the lumbar puncture cannot be done in the first hour, the antibiotics must be given immediately after blood cultures have been drawn. Now, suspected meningitis with signs suggestive of shift of brain or compartment secondary to the raised intracranial pressure. So there is some shift of brain here. You will get immediate critical care input. You will do your ABCs and do the same things earlier. Now you can delay lumbar puncture, and you need to arrange neurological imaging in this case. If the patient has got severe sepsis or there's a rapidly evolving rash with or without signs of meningitis, again, you need a critical care input in this case, and you'll do your ABC. Uh, Here again, you will delay the lumbar puncture. After this, you need to carefully monitor and review this patient. You need to do additional investigation. Of course, you do the blood test, the routine renal function, glucose, lactate, and clotting profile. Apart from this, you need to do meningococcal and pneumococcal PCR and blood gases. Now, unless a clotting defect is suspected, do LP without waiting for the result. Okay, so you need not wait for the INR in this case. CSF, if lumbar puncture is performed, you need to do check for the glucose with the concurrent blood glucose. So whenever you're drawing the LP, of course, you're going to check the serum glucose. Protein microscopy and culture, lactate, again meningococcal and pneumococcal PCR. Apart from this, you need to do the viral profiles. So in that, you will do the enteroviral, the herpes simplex, and varicella zoster virus PCR. You have to do investigation for TB meningitis, especially in cases in countries like India. You do a meningococcal culture, not necessarily required here. So, infection control, you need to isolate all the patients into meningococcal disease until the meningococcal is excluded. or ceftriaxone has been given for 24 hours, or a single dose of ciprofloxacin. Here you need to notify the microbiology. Notify all cases to relevant public health authority for contact tracing. Give antimicrobial prophylaxis and vaccination wherever necessary. How will you treat this patient? So when we will talk about delay in the lumbar puncture, if any of the following are present, if there are signs of severe sepsis, severe respiratory or cardiac compromise, if there's significant bleeding risk, if there's a shift of brain compartments, like got focal neurological deficits or papilledema, or the continuous uncontrolled seizures, or the GC is less than 12, puncture can. Alternative initial antibiotics, you start with penicillin, cephalosporin, anaphylaxis is present, then you can give chloramphenicol 25 mg per kg IV. If the patient is more than 60 years old and not allergic or compromised, include alcohol dependency and diabetes, you give ceftriaxone or cefotax 2 gram IV, plus you need to give amoxicillin 2 gram IV because you're suspecting listeria in this. If the patient has got anaphylaxis for those, then in that case you go for chloramphenicol and cotrimoxazole of the trimethoprim component in 4 divided doses. Now, the antibiotics which I'm talking about are strictly for the NHS. Of course, in India, we don't use those. We don't use chloramphenicol anymore. We are more reliable on, we don't have penicillin here. We are more reliable on ceftriaxone, and we start with the cyclovirus if encephalitis is suspected, and if it does not work, we usually switch to vancomycin, which is a very, very good drug in that case. Then that having been said, that's strictly for Indian patients in India. This okay. So the recent travel or risk of penicillin-resistant pneumococci, you give ceftriaxone plus you give vancomycin or rifampicin. Okay, so you give vancomycin 50-20 milligram per kg or rifampicin 600. So this is important. This is fairly important for you, antibiotic and the alternate. So we'll take some questions. Let's see what are the causes. Just let's go through the causes of meningitis. In 0 to 3 months, it's group B streptococcus, which is most common cause in neonates. E. coli, Listeria monocytogenesis. 3 months to 6 years, it will be Neisseria meningitidis and Streptococcus pneumoniae. H. influenza. 6 years to 60 years, it will be Neisseria meningitidis and Streptococcus pneumoniae. More than 60 years, it will be Streptococcus, Neisseria, and Listeria. So, 3 months to 6 years, Neisseria, Strepto, and H. influenza is important here. Baki, Neisseria, and Strepto remain the same for all of them after 3 months, and Listeria will need to be added after 60 years. So, in this case, you need to, and immunocompromised, you need to add amoxicillin or ampicillin in the treatment profile. When you do the CSF profile, which will tell you what type of infection that might be having, bacterial will be cloudy, it will have a low glucose because the bacteria will eat up all the glucose. Protein will be very high, more than 1 gram. White cells will be 10 to 5,000 polymorphs per mmQ. Viral, again, can be clear, cloudy. The glucose will be 60 to 80% of the plasma glucose. The protein will be normal. Lymphocytes will be high, so 15 to 1,000 lymphocytes can be expected here. Tuberculosis will be a lot of proteins, much more than 1 gram, and lymphocytes will be high and not polymorphs, but anything can occur. The protein will be much, much higher than the bacterial, and that will form the fibrin webs. Glucose is low. Fungal, it's cloudy, glucose is low and protein is high, and lymphocytes will be around 20 to 200. So the Z-Nielsen is only sensitive 20% of the detection of TB, and therefore the PCR is sometimes used. Mumps is unusual in being associated with a low glucose level in a population of cases. So a lot of questions might be targeted on mumps. A low glucose may be also seen in herpes and so mumps and herpes, being viral, still can project with low glucose in the CSF. Then how will you manage? We saw the all component, we saw the warning signs. What I want you to do is look for whom the prophylaxis is required. So how will you manage the contacts? So the prophylaxis needs to be offered to households and close contacts of patients affected with meningococcal meningitis. And the prophylaxis should also be offered to patients who have been exposed to the respiratory secretions, regardless of the close contact. So anybody who was in contact in the first 7 days but persists for at least 4 weeks. So 7 days before the onset, you give oral ciprofloxacin or rifampicin. Now state while ciprofloxacin is the drug of choice here. If both are there in the option, you will use cipro. Meningococcal vaccination should be offered to all the close contacts when serotype results are available, including booster doses to those who had the vaccine in infancy. For pneumococcal meningitis, you do not require prophylaxis in general needed. So there are, however, exceptions to this. If a cluster of cases of pneumococcal meningitis occur, then the HPA have a protocol for offering close contacts antibiotic. Okay, so you are going to give prophylaxis to people who are exposed to meningococcal infection, not to pneumococcal. So it's not. We go through some MCQs. I'm fascinated about the AI questions. So check an answer to fever, headache, neck stiffness, and non-blanching purpuric rash. Where did I told you we see rash? So she appears unwell and lethargic. She developed a mild rash while taking penicillin. So she has got some rash after taking penicillin, but that was when she was a child, not right now. So it's a very mild rash. They have suspected meningococcal. So what will you do? What will be the next step? Don't have a lumbar puncture. So you will give penicillin immediately here, or will you give chloramphenicol because you think you might have allergy to benzyl penicillin and then transfer her? Or you might withhold the antibiotic because you want to do LP and you want to do cultures. So I'll tell you one thing, you don't have that much time here because if you can't do it within 1 or 2 hours, then you might as well give the medicine and then transfer. Now, since the patient has got mild rash and in child, so this is a deflector so that you will answer this. And however, in this case, benzyl penicillin will be the best treatment. Yeah. Administrating intramuscular benzyl penicillin immediately is the correct choice. In suspected meningococcal, early administration reduces mortality because it's a life-threatening condition at this point. So, a history of rash with penicillin is not a contraindication for its use in the emergency situation. NICE guidelines recommend that unless the patient has got a severe allergic reactions. This is something which they can control of. So, mild rash with the penicillin, you still administer in emergency conditions. 18-year-old university student comes to emergency with a 2-day history of fever, headache, neck stiffness, and photophobia. She's febrile, she's got positive connexin and bruising keys, LP you perform, and CSF you get cloudy, glucose is 1.8, protein is high, white cells are predominantly neutrophils. What is the most likely causative organism? So we're looking at something which is increased protein and neutrophil. So it's a bacterial meningitis. So it's most likely Neisseria because of the predominantly neutrophils. Okay, so there's only one condition which should be in the highest list of you, that is bacterial meningitis. Rest of them will have lymphocytes. 68-year-old woman is brought to emergency by her family due to 2-day history of worsening headache, fever, confusion. She has got CLL, okay, and she's receiving chemotherapy. So she is immunocompromised here. She's got fever, drowsy, neck stiffness, and raised WBC with neutrophils. So again, she's got some bacterial infection. And the LP shows raised opening pressure, increased protein, increased glucose, leukocytes, and polymorphin leukocytes. So it can be any of these, but since she's immunocompromised and more than 60, so it will be most likely Listeria monocytogenesis. So this is a gram-positive bacteria, and it is especially it should ring bells in when you're dealing with high risk groups, and these includes uh, the neonates and pregnant and elderly and suppressed individuals. So in patients over 60 years, listeria becomes an important consideration as a causative agent. And moreover, immunosuppression such as that seen in patients undergo chemotherapy for CLL further increases susceptibility to a listeria. And the CSF finding describes raised opening pressure, increased protein, decreased glucose, predominantly PM and leukocytes. And therefore, considering her age, you will select listeria. An 18-year-old university student is admitted to the hospital with a headache, fever, and neck stiffness despite treatment, and he deteriorates and passes away. Blood culture confirmed Neisseria infection. His flatmates are concerned about the risk of infection. Which of the following is the most appropriate management for his close contacts? So, Neisseria, that is meningococcal meningitis, is confirmed. So, in this case, definitely you will offer meningococcal vaccination to all the close contacts immediately. Provide prophylactic oral to okay. You will provide prophylactic oral ciprofloxacin to close contacts. Okay. So this vaccination may be considered when the serotyping results are available. Okay. Because vaccination is not going to provide immediate protection, it will not eliminate the need for prophylactic antibiotics. A 28-year-old medical student is participating in clinical placement, and she assists in the care of 22-year-old man who is admitted with meningococcal meningitis during an episode of coughing, coughs on the student face, the concerned. So you will have to give prophylactic ciprofloxacin here as well. At any time you find the speed is very overwhelming, please you can reduce the speed and you can pause for a second for reading the questions. 72-year-old man presents for emergency department. He has no significant past medical history on examination and he's febrile with temperature of 38.6 5 degrees, and he has a positive chronic signs and lumbar puncture is performed, and the CSF shows the following. So it's cloudy, WBC is high, neutrophils, lipoprotein. Okay, so this looks like bacterial. So it's 72, not immunocompromised. They are telling you it's not listeria. So this patient can be either strepto or the patient can be Neisseria. But in more than 60, streptococcus is the most common cause. So you need to know the table of most common, very important. Okay. So again here, most likely causative is strepto. This factor, CSF, elevated opening pressure, okay, can be there in any of those. A 65-year-old meningitis emergency, sudden onset fever, neck stiffness, family, relatives had flu-like symptoms. Hypertension here exhibits photophobia. CSF is differential, so most likely is protein is high. Even its neutrophils 65. Sudden onset. So this is sudden onset and he was in the gathering with flu-like symptoms. So flu-like symptoms will go towards meningococcal, that is Neisseria meningitis. Okay. So the patient has close contact and family, so that can be bacterial meningococcal outbreak, and if they exhibit flu-like symptoms, this indicates potential exposure to the Neisseria organism. So that's why this will be the answer. What about a 65-year-old man presents to the emergency and he's got fever, headache, neck stiffness, his temperature is this, and okay, he appears drowsy and exhibits focal neurological deficits on examination. There is no rash, he has no significant past medical history. What is the most appropriate next step in management? So we spoke about the table, and 12-hour fever. He's come with meningococcal signs, but he's not requiring any urgent treatment. So you will give delay administer isoclopar immediate lumbar puncture to obtain that. Yeah, so no, they're giving administer IV antibiotics and obtaining blood culture is the most appropriate next step. So the UK guideline recommend prompt initiation of empirical antibiotic therapy in suspected bacterial meningitis, especially when signs of raised intracranial pressure are present. Blood cultures should be taken before antibiotics to help identify the causative organism, and dexamethasone should be given alongside antibiotics to reduce the risk of neurological complications. Delaying the treatment could worsen the patient's prognosis. So, more than obtaining a lumbar puncture, blood cultures are much more important. That is what we learned from this. Yeah, I think that is enough for the base, forming the base to solve and attempting questions on meningococcal. That's all from my side, and all the best for your exam.